Okay, so let's get started. Sorry about that. So again, my name is Kate Cohen, and I work at the Colorado Department of Public Health and Environment as the peer-to-peer shared risk and protective factors network lead. And so as we get started, I want to introduce Lindsay Myers, but before I do, I'm going to just go over a few housekeeping points and a reminder of what this network is working on. As you all know, this network is meant to increase learning opportunities and capacity for members to work on shared risk and protective factors that impact multiple forms of violence and injury, including opioid overdose prevention. And so we host these quarterly webinars with that aim. And last time we discussed the shared risk and protective factors approach in general and how to communicate it. And today, Lindsay is going to be talking about braiding and blending funding. And in the future, we'll talk more about other topics like data and evaluation and other topics that we've heard from you all. So, but please let us know if there's anything you're hoping we can cover, or if there's something you'd like us to present on from your own experience. And we'll also send out a survey at the end of this webinar, so you can let us know then as well. I also just wanted to make a quick announcement. I know many of you applied for funding to attend the Shared Risk and Protective Factors conference and meeting in May in Colorado, and where we're going to just continue to workshop this approach and hear from all of you. Applications closed at the end of January, but for those of you who applied, you'll hear back soon about whether your application was accepted and more details to come about the funding logistics. But for today, I think you're all going to get a lot out of this presentation, and hopefully you'll be able to share the recording with your colleagues who weren't able to attend. So Lindsay is the branch chief for the Violence and Injury Prevention Mental Health Promotion branch here at the Colorado Department of Public Health, and has done a lot of really amazing work over the years with our many violence and injury prevention programs to bridge different funding sources and strategically leverage work across the branch so that we can make the biggest impact possible with what we have, and in particular leveraging the shared risk and protective factors approach. So she's definitely been a leader in this field, so I'm excited to hear from her, and hopefully this will help you all in how you're approaching your own work. So I'm going to hand it over to her. Thanks, Lindsay.
Great. Thank you all. I'm happy to be able to join. I was unable to attend the first webinar that we had, so I apologize in advance if any of this, you see some familiar slides if you were on that call. I also know that I see lots of people continuing to say, give their names and places they're from. Please continue to do that. If you have questions as I go on, feel free to type those in the chat box as well. And I told Kate if it seems relevant, she can interrupt me and read the question out so I can address it if it's on a particular slide or something. And if not, then I will be happy to entertain questions at the end. And if there's time, I would love to hear about what you have going on in your states and ways that you've figured out how to braid and layer funding as well. And then one last housekeeping thing before I get started, if you wouldn't mind muting yourself, or Kate, if you can go through and mute people just to minimize background noise, that would be great. Great. So there's lots of reasons why we have been very passionate in Colorado around taking a shared risk and protective factor approach to injury, violence prevention, substance abuse prevention, and you see some of these things listed here. Obviously in this field, and until actually the emergence of all of the opioid funding that we all have and are starting to use and work with. The resources were pretty limited for injury and violence issues. And so we really feel it's important to prevent multiple outcomes at once using the same strategies if we can. Building new partnerships is something that's a big benefit of using a shared risk and protective factor approach. And just being able to expand your pool of strategies outside of public health. But what I'm going to focus on today is really leveraging resources and funding and the benefits of that, and the outcome that diversifying your funding can have on sustainability for your programs is something that we have seen in Colorado as we've practiced braiding and layering funding over time that we get a little bit better and better at figuring out how we can make all of our funding sources work in concert with each other, but still adhering to all of the fiscal rules and things that govern each of the funding sources. That's what I'm going to talk about today. Just as a quick recap to help frame how we look at our work in Colorado, and I know this is not new to many of you on the call and is similar to how you think of your work as well, but we really aim to create healthy, thriving, and resilient communities that are free from violence and injury. And we want to do that by really focusing our efforts at the organizational, community, and societal levels to improve the environments where we live, work, learn, and play. And a big piece of that is pooling resources and sharing the work so that we can address things like social determinants of health and other issues that are hard to address, and definitely hard to address if you have really limited resources. So some of the outcomes that our branch focus on are here in the slide. I'm guessing many of you on the call have similar setups and things within your departments. I know each state is and local community is set up a little differently, but in our branch, we really strive to address all of these outcomes and measure all these outcomes, and as much as we can take a unified approach to leveraging our funding and the strategies that we're doing to impact these. We know that 80% of our health is really those social determinants of health and economic factors. And so ensuring equity and health equity is also at the heart of what we do. This is a snapshot of our strategic plan that we use for the branch. And I'm not going to go into it in detail, but I want you just to sort of see when we set up our work in the way that we have around really focusing on 4 key priority areas of connectedness, social norms, behavioral health, and economic stability and supports, that doing that and being successful at figuring out what it means to do that and how to leverage your resources to make that happen is really central to the approach that we use. So this is kind of a logic model type page from our strategic plan that I view as primarily a communications tool to help unify our work across all of the various topic areas and funding sources that we have in our branch. I think we have 35 plus funding sources right this second that we manage, and trying to figure out with each of those, when we apply for a new funding source, when we start a new project, how can we build on the work that we've been doing in service to these priority areas so that we can have an impact on the outcomes across the board that we care about. And you will hear me talking a little bit about the socio-ecological model. This is really at the heart of what we do. And as I mentioned, our organization really tries to focus more at the organizational, community, and societal level with the work that we do and with the work that we fund our communities to do. There's some exceptions to that, and I'll mention a few of those as we move around, but a really central part to help grounding the work and also to help figuring out not only within our branch, but also within all of the different state agencies and other people that are touching issues like substance abuse prevention. How can we use the socio-ecological model as a way to lay out how things are funded and whose projects align across state agencies as well as internal to the programs that we have here. So why explore braiding and layering? I have been part of a project that ASTO is doing in concert with CSTILTS at CDC to really provide some technical assistance to states around braiding and layering funding. And they graciously let me steal a couple of the slides that are part of a toolkit that they're developing. And I have been providing some information and some, I guess, consultation to some states on the more programmatic side of how you braid and layer funding. Their project is bigger than that and looking at, how do health departments fund foundational capabilities that you'll see at the bottom of the triangle on the slide here, like leadership and governance and IT support and those types of things. And we have examples in our health department that do that as well. I'm going to ground it in the program side of things, and that's what I've been doing for this project. But the reasons why you want to think about how you're braiding and layering your funding is because it is very difficult, especially as the public health system moves into what they call kind of the public health 3.0, where we're really talking about public health's role in addressing the social determinants of health, that it's hard to do that because there's not dedicated money sometimes, particularly for public health, to play that role. So by braiding and layering funding and looking at these root causes that a lot of our funding sources are trying to get at, this is really a benefit. As you know, there's also, funding historically has been very categorical. And I think, sometimes, and we certainly have been in this place where, you have funding sources and you hire staff that are just dedicated to those particular funding sources, and the projects are kind of self-contained and you don't think about how they're intertwined or how they're intermixed. And I think this is, by thinking about how your funding is working together to achieve a common goal, there's some power in being able to think about it in that way, and then actually do have more ability to address social determinants of health. And obviously this is a lot about the ability to achieve population level impact. We know, I have an example in a later slide around a program called Sources of Strength, which is an evidence-based program for suicide prevention. And, it's one of the few out there that's on the evidence-based registry. But if we just fund one school at a time, we're never going to see a population level impact. And so trying to think about how can, if we have a program or initiative that seems like it's working, how do we actually fund that at a level that might see success? And that's something that we've been challenging ourselves to think about here in Colorado. So what are braided and layered funds? So these are 2 or more funds used in a coordinated manner to achieve a common set of goals. And I'm going to walk you through sort of the differences, slight differences between what braided means and layered means. And then give you some examples from our work from our overdose data to action project, so you can see how we've thought about some of these things. So using braiding and layering funding mechanisms allow health agencies to implement cross-cutting initiatives focused on specific populations, health equity, social determinants of health, while still achieving the program goals set forth in the categorical funding announcement from CDC or from another federal funder, foundation, or state funding. So the idea here is that you're still staying true to what the money was intended to do. And it does require thinking about how you're communicating to your funder around how you're going to use the money. And so everything is on the up and up, but they can be braided and layered, and we have had success in doing this on a number of projects in a way that actually helps us make projects bigger than any one funding source could at the time. So important characteristics of braiding and layering. There's several different models. We have spent some time, and Kate has been trying to help me sort of think about different models and frameworks that can be used to explain sort of these types of things. But they have some common characteristics that are common no matter what combination of ways that you're looking at how you might be layering or braiding your funding. So, you're allowing leveraging of resources for initiatives or infrastructure that lack adequate financial support. You're figuring out how to meet and stay accountable to the reporting requirements of your categorical funding. And it's important to know that these aren't really commingled funds or blended funds. Those words make CDC and other funders sometimes very worried. So, and I think the difference there between what's braided and layered versus what might be considered commingled or blended is really about how you're reporting outcomes and how you're capturing what piece of money is going towards what, and that communication piece, so that people know what they're funded and how each funding source is contributing to the whole project or initiative that you're trying to achieve. So this, again, I borrowed from from the ASTO project, and they allowed me to use this slide, which was nice. And this is how they describe braided funding. So funds are allocated from multiple sources to support a single contract or initiative. We combined and detailed reports ensure good accountability to funding. Expenditures are tracked and reported by the funding source, and the program reporting incorporates requirements of individual funding streams, but may include broader goals. So you can see kind of in the visual here, the starting place is really, what's the win-win here? What is the common goal between funding sources, or if you're thinking at the strategy level between agencies, between agencies, how can you start at that common goal? And then how are you going to lay out what funding can pay for what process? But then hopefully you're able to kind of braid that funding in on the back end. So what contract might go out to a community, for example, if it's a community grant, that's happening in a single contract process versus having 3 different funding sources coming from the same branch or program that are piecemeal braiding these different pieces of a project and resulting in a lot of extra contracting work, etc. So we have lots of examples of braiding funding here within our program, and also now between different programs in our division and our department. Layered funding is a little bit different. Still starts out with the collaboratively determined goals, but makes it a little bit different in terms of what is funding what type of project. So in this example, you may have one particular funding sources that are funding a couple of the activities, and that's the pie chart at the bottom there, while another funding source is, funding activity 4 and funding activity 3. And so you're kind of looking at the project as a huge piece of pie, and you're divvying up sort of what is funding that piece of that activity across different funding sources. And you may still be able to do kind of a braid and layered approach where you're still combining some of the funding on the contracting side, or maybe you still have to have separate contracts because you live in different agencies and it's difficult to do, but you know that you're together funding this whole initiative or this whole project. So this is what I mentioned at the beginning, that we have, just to give some examples of how we've thought about this work. This is, play obviously off this socio-ecological model, and this is an exercise that Ali Maffey and others who are on the call went through to try to look at, okay, for youth substance abuse programs, what agencies are funding what, and at what level of socioecology? Because we know that in a particular community, in an ideal world, the community has all these things going on. And these are just some examples at each of the levels. There's obviously more programs and policy work, et cetera, that could be contributing to this. But trying to think about, between state agencies, what is the common goal and how do all of the strategies fit together? So what you see here is an example that's sort of in the top part of the socio-ecological model around upstream prevention, early intervention, and then more sort of the treatment recovery side of things on the left-hand side, and then socially ecological model examples of strategies at each of those levels. And in parentheses are crazy acronyms for our for our state agencies, so you don't need to worry about that. We're CDPHE, so you can see where the health department fits in some of these things. But this has been a really helpful visual to try to explain how, how we can align all of the different work that's happening throughout the state across different state agencies, and think about what are the opportunities for us to truly braid and layer funding versus what just we want to say, okay, our Office of Behavioral Health that sits at Human Services is going to really focus their efforts on individual and relationship level programming when they send money out to communities. And when we send money out to communities, we're going to focus on the outer layers of the socioecology. So there's lots of different ways to think about it, but kind of starting at a place where you're kind of mapping out what the landscape is, and then again, looking for the win-win is really important. So I'm going to walk through 4 examples that are all associated with our overdose data to action grant and that we're currently working on, but I think you'll see how some areas from that pie chart are on the previous slide. These are agencies that are now contributing to these projects, and those conversations of mapping out what niche does each unique partner play and how does it all fit together helped us get to the place where we are today with some of these projects. So the first example of braided funding is what we're calling the Healthy Youth Campaign. This is a strategy that we wrote into our Overdose Data to Action project under Strategy 9, for those of you familiar with that. And it really came about because we had different campaigns happening in our division, which also houses, in addition to my branch, houses tobacco, houses other kind of non-infectious disease programs throughout the division. And we, like most states, had a lot of work happening for campaigns in the tobacco realm. We also have some state funding for doing education about retail marijuana policies and laws and kind of what our laws are here, but also around youth prevention. And then our sister agencies at our Department of Human Services also supporting a number of campaigns related to youth and protective factors and positive youth development along their side of things too. So what we did is we took a look at that and said, well, is there some efficiencies and some money savings if we don't have 3 or 4 different competing campaigns that at the heart of them really are geared towards impacting the same risk or protective factors? Can we figure out a way to do this on the back end where we do one unified campaign across state agencies and internal to the department? And so we came up with a collaborative goal to impact multiple health behaviors and outcomes, including tobacco, marijuana, opioids, alcohol, and other substance use or risky behaviors through a culturally responsive, strengths-based marketing and outreach campaign. And that was I wasn't directly involved in some of these conversations, but those on our team say it was not super easy to get to necessarily a agreed upon goal at first because, for example, the marijuana program, which is housed in our branch, and the tobacco program had never worked in this way together and really tried to look at, can we find some alignments of our campaign goals and how does this work with our unique funding sources and what we have to report to the legislature in our case or to a federal funder in or state funding for tobacco. I think they have a state and federal mix there. So we were able to work out some of this campaign stuff. So we combined funding sources from tobacco, our marijuana funds, and our Department of Human Services also did an interagency agreement to us from some of their SAMHSA funding to actually support the campaign. And then when we were writing the Overdose Data to Action grant, we realized, oh, we don't actually have anyone to manage the campaign and to tie all these pieces together and to make sure that we're doing all the evaluation and things like that. So what we wrote in our Overdose Data to Action grant was basically providing the staff support. We didn't have enough money, given all the strategies and the mix of things there, to say, okay, we're going to fund, contribute in any meaningful way to the placement of ads and actually implementing the campaign, but we could do this very important piece of adding overdose data to action funds to help support a staff position to align all of this and make sure that the campaign and the messages that are there are just as associated with overdose prevention efforts and awareness and stigma reduction and all of those good things as they are for all of these other topic areas that we are kicking in money. So the contracting process, we pooled all the money on the back end in kind of the, unique funding streams that can fund different things at different times. There's also some different funding sources or timelines associated with these funding sources. So, some of the SAMHSA money, for example, is on a federal fiscal year, which is different than our state fiscal year, which is different than Overdose Data to Action's fiscal year. So some of, what is paying for what portion of this campaign really depends on the timing and how this all works out. But ultimately, we were able to do a single contract to a media agency. And all of that braiding of funding happens on the back end. And so to the agency that's receiving it, they just know they have the funding to do the work and to do the media placements and things like that. We were also able to leverage an existing contract that was in place already to evaluate our retail marijuana education programs and get them to add outcomes related to these other topic areas into the formal evaluation that we're doing for the campaign, so that we could make sure to report back to each of the funders outcomes that are important to that particular funding source, so that we had something to say. I say I have a half-done slide here with staffing, but I did kind of just mention this around the overdose data to action money contributing to the staffing there. And then, as I mentioned, the evaluation happens. So this campaign right now is going to launch very soon. So we'll start to see how this works in practice. But I think it's a good example of, really thinking creatively. I don't have the exact dollar amount in my head. I know Allie Matthews on the call, and she probably does have it in her head around what the cost savings of doing this approach, just in terms of, not having to pay multiple vendors to do the same types of functions for these campaigns are saving across the board. And thanks, Allie. It's at least $200,000 that she just speech-headed. So, I think this is another reason why it's important to look at this approach. Another very central example of layered funding is in our branches, communities that care. So this, for those of you who are not familiar, is really a public health community organizing approach to getting communities to really dive deep into their data, identify risk and protective factors, and then evidence-based strategies to address them, and really getting the community to own the process. So we had a unique opportunity several years ago to take some of the retail marijuana education money and put it into communities that care. And at first, our legislature really was funding this because they wanted to prevent youth from using marijuana, and that was really their primary interest and what the money was for. And what we, sort of pitched in talking to, the people involved in sort of the state funding process around the benefits of using this particular initiative and evidence-based model is that it is evidence-based for multiple outcomes, and the risk and protective factors that communities work through to identify and look at their data really are tied not only to marijuana, but also to other substances, to violence prevention, to tobacco prevention, etc. And so really at the heart of this, even from, when the legislature was thinking about allocating funds to us, we were already thinking about shared risk and protective factors. And then once we got the funding, we started thinking about, wow, this is more money than we've had ever going out to local communities. So it's about $9.8 million or so in the appropriation. And the majority of that goes to fund what are now 46, I believe, CTC grantees that are operating in neighborhoods or local cities or counties, or in some cases, multi-county regions, depending on how they defined community. And what our funds, and this was a very intentional decision on our part, was to say, okay, the funding that they get from us has to go to funding the infrastructure for the communities that care process, and not the evidence-based programs necessarily that they may identify as needing to bring into their community, because we know that there are other funding sources, particularly for school types of initiatives and things like that, that happen from Department of Human Services, that communities, if they have the right infrastructure and support and know what they want to use for their data, that they can really take that opportunity, the infrastructure that this funding source built, to be more competitive for funds that are coming from elsewhere. And that's just one example. There's also, of course, foundation funding and other funding from our branch and other things. So what we really, the piece that sometimes is hard is to really focus on the community and societal level strategies that are more policy related. They don't take a lot of money on the ground to do things, but they do take a lot of training and understanding local level policy and getting buy-in from people to make them happen. So that is kind of what our funding goes to, just from the marijuana funds. And then what we've done over time is think about how can we use then this infrastructure that we're starting to build and now write it into other funding sources and other applications that we have so that we can leverage it. So one of the first things that came up pretty soon after we knew we were getting communities that care is the core state violence and injury prevention cooperative agreement application for CDC, which focused on shared risk and protective factors. And so what we decided to do is say, hey, you know, we're really interested, of course, in the substance abuse outcomes that the legislature cares about, that we're able to fund an outside evaluator to track all that. But what we really want to know is, does it also impact injury and violence outcomes? And so we put in our core state violence and injury prevention grants, some money to support a half-time evaluator who then can ensure that those outcomes for violence and injury and the things that are tied to the core grant are part of that evaluation plan, but we're still using, you know, sort of the infrastructure money and other funding sources to actually fund the work going on in communities. We also wrote this into our overdose data to action grants most recently, where we said, okay, great. So now we have, you know, communities that are funded for infrastructure. We've got evaluation, a contractor that's doing evaluation externally, and we also have an internal evaluator that's making sure to look at all of our outcomes across the board and tying it back to our core work. What we really need is to see, okay, can we sort of show that this infrastructure is nimble enough if we have communities that care coalitions and communities that really do have those agency level buy-in, can we then have them work on strategies that are you know, a little bit more downstream and associated with overdose, connecting to law enforcement, naloxone, linkage to care, all of those types of things that are central to the overdose data to action grant. Can we then you know, have some staff support paid for by overdose data to action that can really work with those communities to work on things that are a little bit more downstream of what our original communities that care project were doing, but the infrastructure is still the same and the know-how is still the same. So we are in the process of doing that now. I would say, you know, we in some way, shape, or form are leveraging communities that care for basically everything we do in the branch. And part of that, in feeding into that, is also thinking about what are the shared strategies and the evidence-based approaches, particularly at the policy level, that we can infuse into the menu of strategies that communities are selecting from to use our funding, that we intentionally are putting there because we know they're associated with multiple outcomes. And then can we use this funding to evaluate all of that? Thanks, Sally, just put the menu of strategies in the chat box there. Can we use all of that to be able to then evaluate and show outcomes? So we're in the process of working on that. Another example of braiding funding is our Essentials for Childhood project and various funding sources that we're putting in together to make this initiative bigger than it is. For those of you who know, this is a pretty small CDC grant, $250,000 or $200,000 maybe, that goes officially to Essentials for Childhood, which is about building safe, stable, nurturing environments for children and their families, with the primary outcome for that work focusing on child maltreatment prevention. But what we have really identified, both by looking at, you know, sort of what's in the technical package for child maltreatment prevention, and what do we know about what's happening in the landscape in Colorado, what we discovered is, you know, Colorado has very low enrollment among eligible people for SNAP and WIC, and in particular counties where there are also high rates of child maltreatment, and the same counties which tend to be higher for drug overdoses as well. And so we are pilot testing in 6 local public health agencies how we can braid funding to support the infrastructure at the local level to be able to really do a good landscape assessment to assess, you know, what are the barriers to accessing these food assistance programs or child care services, treatment services, prevention resources, etc. And then how do we address them? And the group of counties that we have working on this are pretty different from one another. Many of them are very small and rural, and then the city and county of Denver is another hotspot area. So kind of looking at what those barriers are really as we're learning more are in some cases very different county to county, and some are more state level policy types of things that that we can address. So for this one, we had enough money in our Essentials for Childhood funding to support giving these communities about $10,000 to support their time and effort on this project, which we knew really was not enough to do anything. So we looked at our child fatality prevention system, our child fatality review. We have some state funding for that program, and thought, okay, well, these are, it is addressing, substance abuse and also child maltreatment and other things. And so can we look at, linkage to food security and child care assistance programs and other types of things as a strategy that's cross-cutting? And we felt that it meant the intention of that state funding. And so we kicked in $10,000 from that system to support efforts. So now we're up to about $25,000 or $20,000 for each community. Still not enough to hire a full-time staff person to really be engaged, particularly in the small communities that might have health departments that have 2 or 3 people total that work across public health and environmental issues. So when Overdose Data to Action came on board, we took a look at the literature and thought about, well, what, how does linkage to food and child care intersect with substance abuse in communities and overdoses? And we're able to make the argument to CDC that access to these key things like food are really addressing a social determinant of health that should be protective for overdose related outcomes. And there's also an opportunity to really focus some of the efforts and identify specific barriers to people who may be in treatment for substance abuse or maybe accessing child or harm reduction agencies, et cetera. So we were able to use about $30,000 from the Overdose Data to Action grant, kind of make that project whole. So the communities are getting now a little over $50,000 to really do the work that they need, which honors the time that they're spending and really gets them to engage with us moving forward. And again, then on the evaluation side, we're evaluating for child maltreatment outcomes. We're looking at child fatality in a broader sense and making sure that's tied to the child fatality review teams for each of those counties. And then also looking at our substance abuse outcomes and linkage to care types of indicators and things like that with this project. And then lastly, I'll mention some of our harm reduction initiatives, which are fairly new and very complicated. So I kind of consider them to be both braided and layered funding in combination in different ways. And so, overall, we have a shared mission to reduce drug overdoses, substance use, as well as, some diseases that can be spread from people who are injecting drugs, like Hep C and HIV, among other types of things. And we increasingly have a lot of funding sources that are looking at different aspects of this issue. So Overdose Data to Action had a specific focus on linkage to care. We have some state funding for a harm reduction grant program that's focused on looking at building relationships between law enforcement, public health, and harm reduction agencies to help facilitate people getting into treatment and warm handoffs. We have an naloxone bulk fund, which is meant to subsidize naloxone to make it more available to entities that have standing orders in our state. Our Department of Human Services has bunches of stamps of money that are focused on some of these aspects. And so what we've really tried to do, and really are in the process of doing right now, is working across our branch and the programs that we oversee in our Overdose Data to Action grant, but also our disease control partners that sit somewhere different structurally in our state, in our health department, as well as looking at our other state agencies that are touching this issue and really laying out how all the funding is coming together. And in some cases, we are able to sort of braid funding by doing interagency agreements or internal MOUs and agreements between our programs to kind of braid funding on the back end and then get it out the door in a unified way to the contractor for their work. In other cases, we have funding sources that absolutely cannot pay for things like syringes, and the state funding source that says in statute you can use it for syringes. And so, how do we look at it in a holistic way for a syringe service program or a syringe access program that wants to become a syringe service program, to say, okay, we're going to use this money to buy naloxone, you're going to use this funding source to pay for your syringes, you're going to use this funding source to pay for treatment, and this funding source to support sort of the linkage to care and facilitating that process and all the data collection that goes with all of those things. So we have lots of, on the staffing side, shared positions that are funded across multiple sources to help keep things coordinated and make sure that people are, working in concert with each other. And then, sort of a complicated landscape of contracts in these different scenarios. But at the heart of it is always, okay, how can we accomplish the goals that we, collectively want to go in the most streamlined way possible, in a way that saves us money, that makes things less burdensome on the part of the contractor, so that we are good stewards of all of these resources. And then how do we put data systems in place so that we're tracking all of the information and making sure that we can report back to the funders for each of these different things what they care about, while also sort of achieving this large goal. So it takes lots of coordination and lots of sort of creative thinking around how to make the contracting process as smooth as possible when you're doing this, because it can take some time. But I'm excited about it because I see these projects, turning out so much bigger than they would have if I would have just said, for example, okay, strategy 6 is linkage to care and the overdose data to action grant, and I'm going to contribute to it in this one isolated way. Looking at across how we can leverage the funding sources and measure the contribution of any one of them, but try to figure out how we can work together, I think gives it a lot bigger ability for success. And then lastly, this is just sort of, demonstrating kind of how internally here we, approach grant writing and approach our funding sources when they come to be. We literally throw things up on our whiteboard. We start, seeing, so this is from our core state violence and injury prevention grant. You can see, CTC there, essentials there, different types of programs and all of our outcomes and target areas. And we're trying to figure out, how does it tie to our strategic plan? How do we piecemeal this project together? So, thinking about how you're potentially going to braid and layer funding when you're starting your application is very important. And then tracking back, we really try to ground ourselves again in shared risk and protective factors. This particular screenshot comes from Communities That Care, and some of the language is a little different than what you might see in Connecting the Dots or other similar types of documents, but the concept is the same, that we're trying to look at, okay, we want to pick strategies that hit multiple outcomes intentionally. So we want them to have data sources that we can actually track outcomes, and then we want to think about how we can creatively fund them so that we see a population level impact. And then we are upfront with our funders. So again, this is from our core grant, just some screenshots from our application around, here's how we're going to, focus this project. And then on the right-hand side, you see where we're talking about how the funding is going to work and how we're leveraging the money so that everything's on the up and up. And you can see, okay, this much is going to support this person. This is how it fits into the bigger project. This is the contribution that if we're approved, which this one was, to do the work in this way, that our funder is on board and understands the concept. And we're then on our end able to layer and leverage the funding in a way that helps it be more successful. And then lastly, this is just another document we've been experimenting with a little bit. So I thought I'd throw it in here if it's helpful to anyone, around, how do you work with your partners, either internally or externally, to figure out how to start to do this and how to get people to understand the concept and the need to layer and braid funding. And so, we usually start by mapping. So, this is the example from Sources of Strength that I mentioned to you earlier, trying to map out, okay, sources of strength at its heart really impacts connectedness to caring adults, connectedness to school. We know connectedness is associated with suicide prevention, sexual violence prevention, bullying prevention. It's a big piece of communities that care and substance abuse prevention. So can we map all these things together so that we can see, okay, who can fund what and how do things target together? And then you can move into a stage where you're just kind of aligning the work. And this might be more of an example of, how you're kind of building a program so that you are saying, okay, this particular funding source is going to fund the evaluation, this one's going to fund the implementation, this one's going to fund something else, to going to more stage 3, which is fully braiding the funding and thinking about, okay, we're all going to align, we're going to say across state agencies, Sources of Strength is the program that we want to fund, and we are all going to fund it, but we're going to fund it in different schools in different ways so that we can actually expand our reach and be able to see that and then evaluate across the board sort of our collective impact at getting that. I'm not sure this is quite there yet, but I throw it out in case it's interesting to you. And then I just, in closing, want to mention the importance of managing the funding and trying to figure out how all of this comes together, and that you're tracking and you're following all the federal rules and your state rules and the, whatever rules you have. It definitely takes time and budget know-how. We literally before this call just got out of a fiscal meeting where for 2 hours we were, talking about how different funding sources were contributing to what projects, making sure people's staff time hits accurately for what they're funded to do, and those types of things. So this is just a quick, you've kind of a dummy screenshot of one of our fiscal management tools, but really important to think about that, not just about the concept of how you're going to get contracts out the door, but then how are you going to make sure that you're accountable for that money when it is going through. So just in closing here, I think why it's important to take a shared risk protective approach, and how central the funding is to all of that, and to really being able to do that. We have started to prioritize shared risk and protective factors in all of our, in our branch strategic plan, but in program specific strategic plans. For example, there's this sexual violence strategic plan that is completely aligned with our overarching framework that we use around shared risk and protective factors, and infusing that in places so that if those are the documents that you're using when you're then going to your funder to say, hey, I have this creative funding idea about how we can braid or layer funds to achieve to make this initiative better, you've got some grounding in your kind of guiding documents that you're using for your plan. We also always maintain a shared risk and protective factor approach and lens when we're deciding what funding opportunities to apply for, or how to what should be priorities, etc. Really thinking about staffing, and I think some of the examples I shared from our most recent Overdose Data to Action Award, we're really thinking about, okay, if we had a staff person that could actually focus in these areas, we could see more outcomes that are specific to things that CDC cares about in their Overdose Data to Action NOFO. So, can we still build on the programs and momentum that we have with other things, but think about how we staff and how we evaluate to make sure that we're staffed at a level that we can actually pull some of these things off. We try to integrate shared risk and protective factor approach into our organizational structure to help us leverage funding, and figuring out how to cross-train people. And like I said, we have lots of people who are funded across multiple different funding sources, intentionally so, because as one funding source ends, another one begins, and you can build some sustainability for your program that way. And it's a way to, if all you're doing is sort of braiding your funding on staffing, and again, all sharing information with your federal funders so they understand what you're doing and how this person contributes to the project, can really help build some sustainability across the board. So I will stop and leave the last little bit of time for questions. I know that was a lot pretty fast, so thanks for listening, and I'm happy to take any questions if you want to type them in the G chat or unmute yourself and ask. That would be great.
You should all be able to take yourself off mute. So go for it if you're interested.
Yeah, or if you have an example from your state that you'd like to share of anything unique you've done to braid or layering your funding. I definitely know this is not specific to us. It's how particularly violence and injury prevention programs have been scrappy for a long time to try to figure out how to fund things when you don't have very much money. So I know there's a lot of experience on the call as well.
Hi, Lindsay.
Hi, I don't.
Sorry.
Hi, this is Javier Betancourt from Department of Health in Florida. I'm glad to be on the call, and I've heard a lot of really useful information here. We're using a similar approach to our overdose dated action program. Because it's such a large, strategic, blended by nature, unification of funds from CDC. We saw sort of a braided and layering approach naturally to where we came into the grant. So I'm loving what I'm hearing. One thing that I've noted, though, in terms of taking this conversation any further, which we all would love to see, sort of that multi-agency approach that really cuts through all of these little individual programs and the silo effect. It seems like you almost need a high-level advocate or leadership buy-in to get through, and that might be multiple advocates and multiple leaders sitting in different areas. So I don't know if you could speak to that, to sort of strategies that you took to get that high-level buy-in. You talked about memorandums of understanding or agreement, and certainly those are an avenue. But even prior to that step, there might be a way to get that buy-in to come through, because it's kind of like coalition building. But then you've got sort of these disparate, grant pockets of funding, and you're trying to bring them all together in a way that's harmonious, while not losing certainly the individual nature of each one of these as is required by the grant, but creating sort of a greater whole. But there just seems to be a really big leadership picture to this, to get that. And sometimes there's resistance. There's resistance to saying, well, okay, but these are separate. And and it's not, they're not seeing the way that these two might merge. So, if you've had any experience of that, and strategies that we might take to sort of bring our leadership around to this idea of braiding and layering.
Yeah, I think leadership is really the key to it. I think, we have been lucky in our branch to have, 5 or 6 staff members who are really bought into this approach and have had some longevity with, with the team, and have been able to work together to sort of think about, starting off at a place where, we kind of had our own internal leadership buy-in for some of the strategies and how we braid and layer our funding, and trying to do what we can within our little program, to then showing some success there and being able to take that and really work on the communication side to figure out, depending on what the barrier is and what people are concerned about. I think some of the strategies, just in a general sense, are asking questions, and sometimes it's the language or the perceived the way that somebody's perceiving the project that might just need some language shifts. To be honest, we had some pushback initially from CDC on some of the strategies and things that we wanted to do for our overdose data to action project, and had to really sort of reframe and make sure we were using language that was a shared understanding of what we were talking about, and then it was easy to get people to come around. I think another strategy, like with the Healthy Youth Campaign example that I gave, spending some time to do some cost savings. This is what it's going to save the department if we take this approach. So even though it's different, and maybe different leaders and different programs at first were not completely sold, when you look at the numbers, it was easier to convince the higher ups in the organization that this was the way to go, because we were going to have some significant cost savings. So I think sort of thinking through and working through those barriers is important, and trying to be nimble with your language. We in my branch talk a lot about shared risk and protective factors. We even call this peer-to-peer network shared risk and protective factors, but that lingo doesn't jive with everyone, and so trying to figure out okay, what language do we need to use that gets at the same concept. I can reach out to ASTO and see when they're done with their toolkit on braiding and layering. They have some specific sections, one of which is leadership. So I'm happy to get their permission to send that out to this group if people are interested, because it does address some of those things as well. I think Elise, you might have had a question.
I did, thank you. Elise Andrews with the Baltimore County, Maryland Department of Health. I was really interested in your Essentials for Childhood and the reference you made to linking social determinants to overdose and substance use, and how you did that with a mind towards food security. We have in our Overdose to Action strategy working with our substance exposed newborns unit, but it's more of a case management patient navigator piece. So I'm really interested, do you have the research you referenced easily sendable or shareable, or is it something you just went out and tried to find what you could and were able to find research around that?
I definitely have research, and I'm happy to send the references and even the section of the justification that we wrote in our grant to, to kind of talk about that. There's a lot of literature around particularly the connection to food security and child abuse, but we were able to find some that were specific to overdose, and then also just looking at things from sort of a social determinants of health lens. All of these things kind of track together, housing and food and the basics, and so when you overlay the data, you see some of the same the same populations coming out. And but I'm happy to, so I have some journal articles. It's not in a sort of quick summary, but I do have all of the articles, and I'm happy to share them with the group if it would be helpful. Or if you specifically, if you want to stick your email address in there for me, I'm happy to send them to you.
Okay, thank you.
Okay. Well, if anyone has any other questions, feel free to also email them in. We can definitely get back to you on that. But since it is the end of the hour, I want to thank you, Lindsay, for leading such a great presentation. I think that there's a lot more interest here, and I look forward to future conversations that we can talk more about this. I just wanted to make a couple of quick announcements, but before I do, Lindsay, do you have anything else to add?
I don't. Thank you all.
Okay, great. Just that the next learning opportunity will be in May, so look out for more information about that. And we're definitely always welcoming feedback on what you'd like to hear about next, or things that you'd like presentations on. And you can expect a survey for a quick evaluation in your inbox today or tomorrow. That we'll be collecting feedback about how these webinars have been going. So please fill those out, and we'd love to hear from you. But thank you, everybody, for some great participation and a great webinar today.
Thanks.
Bye.